Hi, everyone. So before I start, thank you. Before I start, let's show by hand how many of us have encountered some form of secondhand smoke in a room, probably in a bar or in a pub. Well, I guess we can all relate to this topic. So as already mentioned, I'm Judith Arthur and I'm presenting on spatial and temporal assessment of secondhand smoke exposure to home healthcare workers. Now, who are home healthcare workers? These are skilled professionals trained to administer medical and nursing care to clients in their homes. Now, they include registered nurses, therapists, home healthcare aides. Now, in America, they're amongst the fastest growing population, okay, with a projected growth rate of about 29.9% come 2029. Now, unlike their other colleagues in controlled settings with easy access to sophisticated equipment, economic training, and procedures for reporting hazards, home healthcare workers often find themselves working in quite unique, isolated, and unregulated environments, as such predisposing them to occupational hazards such as exposures to extremes of temperature, exposure to chemicals, exposure to musculoskeletal injuries, and exposure to secondhand smoke. Now, amongst all these hazards, exposure to secondhand smoke is quite worrying in the sense that some clients or their caregivers even simply refuse to stop smoking in the presence of home healthcare workers. Now, secondhand smoke, also known as passive smoking, is made up of the mainstream smoke. Now, the mainstream smokes are emissions that is being exhaled by the consumer, while the side stream smoke are the emissions that are being emanated from the burning end of the cigarette. Now, there are three ways by which home healthcare workers are exposed to secondhand smoke. One, occupants smoke during their visit. Two, prior to home healthcare workers' visit. And three, smoke drifts from other rooms or neighbors. Now, there are no safe levels, and even acute exposures can result in adverse physiological effects. Moving on to the health impact. Secondhand smoke contains more than 7,000 chemicals, including beryllium, benzene, many of which are known carcinogens, okay? And according to the Center for Disease Control and Prevention, exposure to secondhand smoke is linked to an increase of coronary heart disease by 25 to 30%, and that of stroke by 20 to 30%. Now, it's also been linked to lung cancers, reproductive health issues in women, and for children, it's been linked to ear infections, asthmatic attacks, and other respiratory issues. Now, globally, this is still an issue in the sense that more than 1.3 million non-smoking adults die annually from exposure to secondhand smoke. And for us in the States, more than 34,000 die prematurely from heart-related conditions as a result of exposure to secondhand smoke. Now, currently, there's a rise in the use of electronic cigarettes. Why? Because it's often marketed as a safer alternative to traditional cigarettes, which is a lie, I must say. And these emissions contain heavy metals, volatile organic compounds, nicotine, and ultrafine particles. Now, while it's true that emissions from these sources are lesser compared to conventional cigarettes, they equally impact indoor air quality and impact health. Now, as safety professionals or as industrial hygienists, mostly when we are talking controls, we rely heavily on the hierarchy of control framework. And that's what we are going to look to also kind of think of ways to help us control secondhand exposure. So with the hierarchy of control, the best is on top and the least is beneath it. And in secondhand smoke, elimination remains the best, okay? And elimination is actually through establishment or enforcing of comprehensive smoke policies. Now, currently, more than 80% of the world's population is still exposed to secondhand smoke. And for people in the United States, more than 40 are exposed. Why? Because our current policies do not include electronic cigarettes, okay? For substitution, we are looking at nicotine replacement therapies or behavioral changes. Now, engineering controls involve the use of improving ventilation or some form of air purifying system. But mind you, these standalone measures only help dilute emissions, but do not totally eradicate secondhand exposures. Now, administrative-wise, we are looking at educating the public about the ills of exposure, which I believe we are still doing. And PP is the last line of defense. It shouldn't be our go-to effort. But funny enough, that's what's happening. People tend to use most PPEs to protect themselves, and it involves the use of surgical masks and then the N95. So why this research? So currently we have several research that has looked at the chemical composition of electronic cigarettes and then the traditional cigarette, with very little actually characterizing their spatial and temporal distribution, or very little actually looking at the combined effect of these control measures in eradicating secondhand exposure. And so we set out to, first of all, one, characterize the spatial and temporal distributions of secondhand smoke from these sources, and then two, evaluate how masking practices and increasing air change rates influence exposure to aerosols from these sources. So this was our schematic. This is a schematic of how we collected our data, okay? And we employed the EV2 smoke generator to simulate a smoker's profile according to ISO recommendations. Now, ISO recommendation for traditional and electronic smoke has been enumerated over there. I just don't want to go into it because that's not our main focus. So as already established, it's a lab-based experiment. We employed commercial, traditional, and electronic cigarettes. And then to mimic exposure, a mannequin, in this case, our home healthcare worker, was placed at variable distances of about 1, 3, and 6 feet away from the smoke source. Now we used an ELPI to collect aerosols, and we considered 4 exposure scenarios, that is 10 minutes of baseline readings, 10 minutes of active burning, 10 minutes of post-burning, and then 30 minutes of air change rate. And then for our interventions, we actually evaluated the effectiveness of masking practices, and these are the masks we use, the surgical mask, the N95, and then the gas respirator, together with increased air change rate, and then we compare these things to unmasked conditions, okay? Now for our results. Now temporal profiles just shows how exposure changed with respect to time, okay? So during emission for baseline readings, we saw how particle counts were almost negligible. But for traditional cigarettes, during active burning, see how it shoots up. The particle number concentration actually increases for the 1 foot and the 6 feet. This is the 1 foot and the 6 feet. Surprisingly, at 3 foot, it comes down. Now, the common knowledge is that the moment we stop smoking, these concentrations should come down, and that's not the case. See what's happening at the post-burning unit. You realize that concentrations are still high and even higher than the active burning phase, and it's just telling us the persistent nature of residual aerosols even when we stop smoking. Now, when we introduce increased air change rate, see the gradual decline, and it's also telling us about the effectiveness of ventilation in reducing exposure. But this is the takeaway I want us to observe. You notice how the decline is quite gradual and not instantaneous. And it's telling us that these secondhand smoke are tenacious in nature. And so even with introduced air change rate, they really take their time, particularly for traditional cigarettes. Now, in comparison to what's happening for electronic cigarettes, we realize that the emissions are quite fewer relative to the traditional cigarette. And then you actually have an increment in particle count only during active burning and when exposures are closer, but they quickly decline to baseline readings. And it's all because electronic cigarettes are highly volatile, okay? And so once they are exhaled, they quickly return to baseline reading. That being said, we are not advocating that these are less harmful. They equally impact indoor air quality. And there are some studies that have actually linked this to long-term effect. Now, what does this mean for the home healthcare worker? We are saying that even when probably clients smoke 20 or 30 minutes before they arrive, they are still at an increased risk of having the coronary heart disease, the heart disease, and then the respiratory conditions we've spoken about. Now, looking at the spatial distribution, that is for electronic cigarettes and that is for traditional cigarettes. So what we realized was that emissions were finer, with traditional cigarette producing more emissions than the electronic cigarette. And it's because traditional cigarette is made up of the mainstream smoke and the side stream smoke. The side stream smoke contributes more to the finer emissions. And so we have more emissions for traditional cigarettes as opposed to electronic cigarettes. And we realize that the profiles are quite different in the sense that the electronic cigarettes, we have 2 distinct peaks. They are bimodal, whilst the traditional cigarette is unimodal. Now for the bimodal peak, our first peak was the 0.173 micrometer particle, and then the second peak was the 0.655 micrometer particle, relative to what's happening in the traditional cigarette, which was highly characterized by a 0.173 micrometer particle. And we realized that as particle size increased, there was a gradual decline. Now, what does this mean for the home healthcare worker? We already established that they are finer in nature, and it's these finer particles that remain airborne they travel for a long time, and then they remain for a long time. So assuming this happened in a home, then the home healthcare worker is at risk of inhalation. Now, it's these finer particles that is able to travel into sensitive areas in the lung to cause all the conditions we have previously enumerated. Now, at 3 feet, the pattern remains the same. Only the concentration levels are what's reduced. And so the question we are asking is distance having a role to play? Well, let's hold our horses. We can answer that after we've seen if it continues for the 6 feet distance too. And again, you realize that for the electronic cigarette, it's losing a second peak. Okay, again, particles are finer in nature. This time around, the predominant particle size is the 0.173 microliter. Oh, sorry. Yeah. Surprisingly, at 6 foot, we realized something interesting. Concentrations here were higher relative to that of 3 feet. So again, we realized that distance was not really a factor in reducing exposures. Moving on to the effectiveness of intervention, in this place, the masking practices and increased air change rate. So this was computed by comparing it to unmasked condition. And then the general trend here was that for every mask that we used, we recorded some level of reduction. However, the magnitude of reduction was based on the type of masking used and the type of product that we burnt. So for surgical masks, we realized that we achieved about 70% of reduction in aerosols for electronic cigarette during active burning compared to 25% reduction. And for post-burning, we achieved about 50% compared to about 40% in traditional cigarette. Notice how when we increased air change rate, we recorded a significant amount of increase in reduction. So as standalone measures, we didn't get that, but combined with air change rate, we got an increase in reduction. The same was recorded for N95, and then the same for gas respirator. So overall, we realized that the N95 outperformed the gas respirator and the surgical masks. At 3 feet, similar trends were observed, just that at 3 feet, the surgical mask lost its potency in reducing exposure. However, the N95 and then the gas respirator were comparable. The only difference was that their effectiveness was being dictated by the combustion phase. For example, the gas respirator outperformed the N95 during active burning for traditional cigarettes. On the other hand, the N95 outperformed the gas respirator during the post-burning phase and during the air change phase. So together, the N95 was more of a suitable intervention than the gas respirator and then the surgical mask. Again, similar trends were observed. The competition, the bone of contention was between the N95 and then the gas respirator, and then their effectiveness was always dependent on which phase and the type of product that was being burnt. Again here, the N95 was a much more reasonable intervention than the gas respirator. So in conclusion, we are saying that traditional cigarette produces more finer emissions, and with these emissions, they persist longer until an intervention is enrolled. Home healthcare workers have little control over their environment, okay? And their activities such as wound care, administering pills, monitoring vitals, actually bring them in close proximity, close contact with their clients, and so predisposes them to secondhand smoke. And so standalone measures like distancing or masking alone is just not enough to protect them from exposure. And so from our study, we recommend the use of integrated methods where we are looking at engineering controls and a good fitted N95 to actually help reduce their exposure. We also hope that moving forward, our cigarettes, our smoke-free policies is going to be upgraded to include electronic emission so that in areas where we still have active vaping and smoking, that can be controlled. So we thank NIOSH for funding this project, and thank you so very much for our collaborators who helped us in getting this far in our research. These are references we used, and thank you, and I'm ready to answer any questions.
Thank you so much for that great presentation. Are there any questions? Yep, we've got a few questions. Is there a mic somewhere?
I have a question. How long did your research take, and did the results been perfect?
So it's been approximately a year, and with all research, it hasn't been perfect. It's been countless times of going back to collect data, repeating the same samples, just to make sure that they were comparable. Yeah, so it's been a hard 1 year with this project. Yeah, I must say.
I can go without it, right? Sorry, so you go back to the graphs of your production. So I was just curious. I thought that the numbers that you're getting there were probably a little bit, poorer than we would expect for some of the like N95, for example. I was curious if the respirator, so with the bar graph, is the mask fit for these mannequin tests with the like artificial breathing? Curious what the setup. So if we go forward a little bit to the bar graphs with the percent reduction.
Oh, okay.
It's just one of the general challenges of doing this research, right? Is when you're testing these surgical masks at N95 with something like cigarette smoke, you don't have a person sitting in the chamber, right? We're not going to do that.
Yeah.
So was this using the mannequin setup?
Yeah.
Breathing?
Yeah, with the mannequin
so I
setup.
was just curious with like the N95, how big of a factor do you think the fit of that mask on the mannequin is compared to like you've got in this graph the surgical mask and the N95 with the burning phasing kind of similar levels, right?
So I think one of the limitation with lab-based experiments is, like you mentioned, having to have that right fit for most of our mannequins. And we tried, to make sure that at least it was fitted right. But then like all respirators, you know how surgical masks will even fit on your face when you try your best. The same with all the other masks. So we tried, yes, we tried. Yeah, but there was no way to actually ascertain whether it was the right fit, because you don't get the feedback, you don't go through that fit testing phase and all that.
Yeah, it's a nice lead in mind. But I think it's just a big challenge of the mannequins that we have and like getting fit.
Yeah. So I agree with you too, in the sense that, so even our mannequins, we even tried with the mannequins, because the mannequin we used was modeled to mimic the face of a human being. So I think it was half silicone, and then the other was raw plastic. So yes, we would try, but then with all lab-based experiments, there's a limitation to how far you can mimic the real world situation.
All right, thank you. In the interest of time, we're going to have to move on, but I would encourage you, if you have more questions, to ask her them later, maybe during lunch. University of Cincinnati.